Hi, I'm Dr. Scott Lee. Oftentimes I'll get patients and they'll come to me for a second opinion or a third opinion, and they'll say, why is it that my regular cardiologist isn't offering me more advanced therapies? Or why did my regular cardiologist not refer me to an electrophysiologist sooner or period, and I had to do my own research and find a cardiac electrophysiologist? So the answer is, I think there's multiple reasons. See, I look back on the 20 plus years that I've practiced as a cardiac electrophysiologist, and remember, we are specialists within cardiology. We've done 2 more years of extra training to specialize in the heart rhythm. So we're like the electrical cardiologists or the electricians of the heart, if you want to think about it that way. And oftentimes I see this really as a problem. I will see that there are referring regular cardiologists who don't refer patients for atrial fibrillation. It's easy to just chalk it up as, they're just practicing outdated medicine, 30 years ago training, and they just keep doing the same thing. But why is that? Why does that actually happen? And so when I analyze and look back over the last 20 years, I do see some trends that I think answer why this is the case. So let's go back 20, 30 years ago. So when I came out of training 20 years ago in 2003, 2004 for my electrophysiology fellowship at Stanford, electrophysiology was a rather new field, okay? Up until, say, the 1990s to early 2000s, if you're a general cardiologist and you're treating something like atrial fibrillation or heart rhythm disorders, there wasn't a whole lot we could do. I mean, we understood a lot of the basics and mechanics of heart rhythms, and we're able to start to localize where these abnormal rhythm cells were in the heart, but we didn't have really good ways of getting rid of them. Things like catheter ablation, where we put spaghetti-like little wires up your leg veins into your heart to map inside your heart and localize these abnormal rhythm sources, and then use another catheter to burn, freeze, or destroy these abnormal cells to cure people of abnormal heart rhythm problems, was in its infancy. And so therefore, for many decades, people would say, look, you have a heart rhythm problem. We're just going to use medications, because that's all we could use. Whether the medications were to slow things down or try to put the abnormal rhythm to sleep, it's kind of all we mainly did. And so if you're somebody who trained in the 1980s or 1990s as a regular cardiologist, that's kind of all you knew. Now, you start getting into the late 1990s and 2000s, where as electrophysiologists, to map and cure people with ablation procedures starts to improve dramatically, but you're a regular cardiologist, you're not really aware of those kinds of advances. And so you just keep doing what you've been doing and just treating people with medications because that's what you can do. And it wasn't just things like AFib and ablations, it even extended to things like devices. So for example, when I came out of training in 2003, 2004 from Stanford, I remember that there were a lot of regular cardiologists who didn't even believe in implantable defibrillators. Implantable defibrillators are oversized pacemaker type devices that we as electrophysiologists implant underneath your skin with little spaghetti-like wires that go into your heart, and these devices monitor your heart. And if you're somebody who suffers from dangerous, life-threatening abnormal heart rhythms, not AFib, which makes your heart go fast but doesn't directly kill you, we're talking about rhythms that can speed your heart rate up to life-threatening speeds of 300 or 400 beats per minute, where your heart is just vibrating, quivering, and not effectively pushing blood, so it can't circulate blood to your brain and you could pass out and die, which is what we call a cardiac arrest. These kinds of devices are standard treatment therapies to monitor somebody's heart and actually shock them out of it. And yet I had some regular cardiologists at the time who said, I don't believe in that. Just put them on medications, and I really don't believe in that. And then there were things like biventricular pacing, which is pacemaker type devices where we use 2 wires instead of 1 wire to pace the 2 bottom chambers of the heart, the 2 ventricles, in people with weak hearts. By pacing them in both chambers instead of just one, it actually helped the weak heart contract more uniformly or in sync with each other, the 2 chambers, and actually help people's weak hearts beat more effectively. And that was another procedure technology that we started doing in the late 1990s and 2000s. And I had regular cardiologists say, I don't believe in that either. And this term of EP voodoo actually got coined, where people would say, your field is so new, and you guys say that defibrillators help protect people and save their lives from dangerous rhythms, and you say that doing this biventricular or 2-wire pacing helps my patients with weak heart do better, feel better, and have their weak heart just work better. And yet you say that, but I send these people for these procedures and they never seem to feel any better and they never seem to do any better. And that wasn't because the technologies didn't work, it was because a lot of electrophysiologists rush through their procedures, are more focused on doing as many procedures a day as possible so they can make as much money as possible, and they do a very mediocre job. And so if they rush through the procedure and don't put the pacing or the shocking wires in the correct places, it may not work. If they don't put the 2-wire pacing wires in exact proper places, and sometimes it's very hard to do that, and rather than develop the skill, they just put it wherever they can and rush through and get done in 45 minutes or less, and then brag about how many they can do and how good they are because they can do it so quickly, and try to equate speed with quality, which isn't true, and then they wouldn't get the result, and it made regular cardiologists not believe in what we do, and that's a problem. Now fast forward with atrial fibrillation. In the last 20 years, our treatments for AFib have advanced markedly. What used to take 8 hours in 2003 to just do a one-wall AFib ablation, now somebody fresh out of training can do that in an hour, sometimes hour and a half or less, and somebody who's skilled and experienced might only take 30, 40 minutes to do that. And because of that, our ability to affect people with procedures has increased dramatically. Unfortunately, AFib is a complex rhythm problem that progresses in stages. And the more advanced stage you have, the more AFib cells you have on the more walls, and the more advanced the stage of AFib or bigger your forest fire, the more advanced a lesion set is required. But once again, you have the same problem. You have doctors rushing through, doing very simple or mediocre work, doing a one-wall ablation, and the person has 3 or 5 walls of AFib cells in their heart and not getting the result. And as a result, it leads to regular cardiologists, once again, believing, you guys are doing all these procedures, but I don't see that it helps. It's this AP voodoo thing all over again. And so what I'm seeing is, I see some doctors, some regular cardiologists, sometimes well-meaning, but they are practicing outdated medicine. They are aware of more advanced treatments like ablation, but they don't really believe in it. And so they just do everything they were trained to do 30 years ago. Put you on a medication, say this is gonna slow down your AFib, and that's good enough. It's not gonna kill you, you're on a blood thinner, don't worry about it. And here you are suffering from rapid heart rates. All they're doing is putting you on a little bit of metoprolol or diltiazem to slow it down and telling you to tolerate it. Or if they do use an antiarrhythmic drug, like flecainide or sotalol or amiodarone to suppress your AFib, they don't seem to understand the strength level. And they just use them randomly, like, well, let's try this one and let's try that one. And they don't even know which one's stronger or which one's weaker. And then when that all fails and your AFib is so progressed that it's on 3, 4, 5, or 6 out of the 6 walls of your heart, and you're mostly an AFib, then they turn to an electrophysiologist and say, you know, this person's begging me for an ablation. I don't really believe in that, but I failed in terms of everything I can do medicine-wise to just fix them. As if doing an AFib ablation is gonna have the same success rate whether you're at an advanced stage or an early stage. Remember, the stage of your AFib, the size of your forest fire, directly impacts the success rate. And then number 2 is the skill of the operator, and can they even do an advanced lesion set to match your stage. So these regular cardiologists may be well-meaning, but practicing outdated medicine, they putz around until your AFib is completely advanced, and then they can't do anything more, and then they send it to somebody and say, just fix it, as if it's all the same, and no matter what stage of AFib, you're all gonna get the same success rate, and that somehow we all do the same thing, which is completely not true. And they end up sending it to one of these electrophysiologists who are doing one-wall ablations or mediocre work on everybody and bragging about how fast they can do it and how they do 6 a day, worsened by the pulse-filled ablation technology, which came out 2 years ago, which has not been proven to make any more effective lesions, but is a little bit safer and a whole lot faster, so people can do simple one-wall ablations in half the time and do 6 a day and brag about it as if somehow I'm really good because I'm doing 6 a day, even though I'm doing a one-wall ablation on everybody, even the people who need more because they have 3 to 6 walls, and then I just do it multiple times and make more money. So the regular cardiologist who's practicing outdated medicine sends it to somebody like that. They do 3 or 4 ablations, one wall, mediocre work, done in 45 minutes, do their 6 a day, and they don't get the result. And then the referring cardiologist says, see, I was right. This doesn't work. It's just more EP voodoo. These people, these EPs keep saying they can do all this stuff, but it doesn't really pan out. And the mistake here is the person who's practicing the outdated medicine doesn't understand some basics, that certain of these rhythm problems are very complex, and the more complex they are, the more skill the EP needs to get them a good result. They need to put the 2-wire pacing, biventricular pacing wires in the correct positions, which can be very difficult and need more skill. If the person has a more advanced stage of AFib, then you need to go to an EP who actually does more advanced AFib lesion sets. But what I'm seeing more and more of is the easier it becomes for us to do ablation, the more people are doing simplistic ablations on everybody, because they can say, hey, if I do 6 a day, even if it doesn't get me the result, what do I care? I'm getting paid either way, because our health insurance system pays us for doing something, not for quality. So it's volume, not quality. Nobody sits there and says, are you all getting the same result? Which, to assume that all doctors get the same results is just ridiculous in my mind. I mean, I don't know what profession out there on the planet where everybody does the same thing. If you go to a plumber, some are going to do a better job and some are going to do a worse job. If you go to a lawyer, some are going to be better, some are going to be worse. I went to a lawyer recently and they said I charge $900 an hour. But if you don't like that, you can go to my junior associate, which we farm out at $150 an hour, $200 an hour, because they're just fresh out of law school. But you take somebody fresh out of training, an EP fresh out of training, they bill the same as those of us who had 20, 30 plus years of experience. It doesn't make any sense, but that's what happens. And so you get paid for volume. And this belief is we all do the same thing, which is not true. So the problem here is if you're a regular cardiologist who doesn't believe in this, then don't wait until the AFib is super advanced. Catch it at an early stage, then it doesn't matter who you send it to, they're probably gonna get you a good result because easy is easy and hard is hard. A small forest fire, anybody can put that out. A bigger forest fire, not so much. So don't just say, oh, this doesn't work because I waited until the last minute, I waited until the problem is super advanced, and then I just send it to somebody who doesn't even do advanced procedures, isn't that skilled, but does a bunch of simplistic procedures 6 times a day to make money. Well, then you're just gonna reinforce that this doesn't work, but it does actually work. But you just have to understand this. And unfortunately, the other thing I've seen over the last 20 years is more and more EPs just doing tons and tons of procedures and not doing very complex ones and kind of doing mediocre work. Not everybody does that, but a lot are doing it. Because once again, they're playing on the idea that insurances just pay you for doing something. And so therefore, if they say, hey, the insurances keep cutting our reimbursement, we're making less and less, so I just got to do a bunch of procedures. I don't care if I don't do an advanced enough procedure. I don't care if I don't improve my skills to do what's really necessary. I'm just going to do a simple one-wall procedure because it's gotten so easy to do that, especially with pulse field ablation for AFib. I can do 6 a day, and if I don't get the result, every time I do a redo, even if it doesn't get the result, I still can bill for it. So now I make 2, 3, 4, 5 times the money, and I do 6 a day. But the problem is, they say that's going to get back at the insurances because they're not paying as much. But every 3 to 5 years, the insurances say, wow, you guys are doing so many procedures. I guess it's not that hard to do these procedures. I guess we'll just cut reimbursement even more. And then people just look for other ways to rape the system. So this is a problem and trends that I've been seeing over the last 20 years that I don't particularly agree with, but I have seen. And it actually hurts our field for people to do volume and simplistic procedures and not get the results because it makes many regular cardiologists not believe in what we do. And so the answer here is, you want to take the time with patients, make sure that the procedure is actually needed and necessary, not just pushed into it because it makes somebody money, and then actually do a good job. Take the time, get the skills, develop the skills to actually do a good job so that our referring partners, our regular cardiologists, want to refer to us and know that we're going to do a good job. And the more we rush through things and just rape the system and bill, the worse it is and the less referrals we get. But it is a problem that seems to be feeding on each other, and it is something that I think has gotten worse over the 20 years that I've done this. This is why patients need to empower themselves through education and advocacy. You need to make sure that you understand what's going on and that you advocate for your rights. And if you understand what's going on and you educate yourself and you feel that something's not making sense or you're not being offered what you think you should be offered or you're being pushed into a unnecessary procedure, get a second opinion. This is you and your loved ones, and find out what's really going on, and then go to somebody who's going to do what you believe is right for your specific situation. I'm Dr. Scott Lee, and I hope you've enjoyed this video. If you liked this video, please feel free to subscribe. And if you feel like you've got good information from this, feel free to go to my website, drscottlee.com, for more AFib resources. Thank you for watching. For everything atrial fibrillation related, please feel free to go to my website, drscottlee.com, where you're going to find more resources and also can follow me on social media.